When I see a patient with non-small cell lung cancer, the first question I ask myself is, what histology is their tumor? Sometimes that's a challenge. We can get a straight answer from the first pathologist who looked at it, and they'd say that this is clearly a lung adenocarcinoma. Often that is based upon some of what we call immunohistochemistry staining, or staining for particular markers that's done as part of routine pathology testing, things like TTF1 and napsin. In those situations where it's clearly a lung adenocarcinoma, we can move forward. Other times it's difficult, and with the small pieces of tissue that we obtain in biopsies of lung cancer, it can be a challenge, and so it requires a pathologist who's secure in their diagnosis, who can make a statement whether this is adenocarcinoma, squamous histology, or rarely large cell histology, non-small cell lung cancer. Once we know the histology, then we decide what mutation testing is appropriate. In general, for squamous histology tumors, I don't recommend EGFR or any really molecular testing as standard of care today. At major academic centers, including ours, there are research programs that take patients with squamous cell tumors and have mutation testing done on those. Right now, that hasn't been validated as appropriate for standard treatment. On the other hand, for lung adenocarcinomas, there are at least two. I would say that EGFR mutations and ALK rearrangements I would consider standard of care, and if you have the tissue available, every patient with lung adenocarcinoma, large cell carcinoma, should have testing for EGFR and ALK. In addition to those two, I think KRAS mutation testing offers some benefit, and the main reason for that benefit is because almost all the driver oncogenes that you hear about are mutually exclusive, meaning that if a patient has an EGFR mutation, it's extraordinarily rare that they have an ALK rearrangement. Similarly, if patients have a KRAS mutation, it's extraordinarily uncommon to have EGFR, ALK, or any of the other driver oncogenes you hear about. Given its frequency, KRAS mutations happen in over 20% of lung adenocarcinomas. By finding a positive result in that test, makes you feel comfortable that you understand this cancer, and you don't have to worry that there's some other driver oncogene that you're missing for that patient. So I think by doing those three things, EGFR, KRAS, and ALK, you have a very good feel for a large proportion of lung adenocarcinomas, and that's why I recommend that for all patients with lung adenocarcinoma.